You're listening to Finn Voices on Healthcare Now Radio, where we highlight and amplify the voices at the forefront of health innovation that improves people's lives. Join us for an inside look at the change makers driving conversation and answering the most important questions in healthcare today. Thanks for joining us.
Hi there, and thank you for joining us on Finn Voices, a show where we amplify the voices of healthcare innovators. I am your host, Carrie Young, coming to you from the Twin Cities of Minneapolis and St. Paul. I'm a partner at Finn Partners, where I have the privilege to work with thought leaders across the health ecosystem. Today, I am thrilled to introduce my first guest, Bukata Hayes, Vice President of Racial and Health Equity and Chief Equity Officer at Blue Cross and Blue Shield of Minnesota. In his role, Bukata is responsible for the Blue Cross Racial and Health Equity strategy. This includes working to integrate all diversity, equity, inclusion, and belonging efforts across the entire company to fully embrace the values and practices of being an anti-racist organization. Through this lens, he serves as an advisor and strategic leader across the organization to identify and implement initiatives that bring about greater inclusiveness, representation, and lasting change. Bukata, welcome, and thanks for joining us.
Thanks for having me.
So let's start at the beginning. I would love to hear about your path into racial and health equity, and ultimately, how did you land at Blue Cross?
Yeah, absolutely. So again, thanks for having me. Really appreciate the opportunity to come and kind of talk about really important, critical, big issues, right? In particular here in Minnesota and across our nation. So for me, the journey to where I am today started when I was really young. So my father was a pro-Black civil rights activist in Milwaukee, Wisconsin. So I got firsthand sort of on his lap view of working for a community and working in a community where you were not seen as fully as you should have been. You were not participating as fully as you could. And this was in the 70s and 80s. And so I think from that standpoint, I was able to see the impacts of his work on the community in Milwaukee, Wisconsin. I was able to benefit from that work. And so for me, from that really early age, I was able to see and understand the importance of working in community. And then I think the other part of this journey has been my mom. So my mom and dad never married, but my mom raised 4 boys by herself, basically, right? In the inner city of Milwaukee, Wisconsin. She's the strongest person I know. And so her resilience in being able to raise us so that we made it within community, I don't take lightly, understanding what we have seen come to light, right? In terms of young African-American men, in particular, engaging with public safety and police and the fatal outcomes that we've seen. And in particular, we know Minnesota was the epicenter for, in particular with the murder of George Floyd. And so all of that, Carrie, moves me to where I am today. Left Milwaukee, came to Minnesota, went to college, experienced things in college that informed me to this day. And then for the last 15 years prior to coming to Blue Cross Blue Shield, I worked at an organization called the Greater Mankato Diversity Council, doing DEI and racial justice work in a small, basically, community in southern Minnesota. So this idea of how do you talk about inclusion in places that some folks may not want to talk about inclusion was basically a training ground for these really tough conversations, how you bring folks in, how you move systems, how you move communities to care. And so then joined Blue Cross Blue Shield on March 29th, 2021 to lead their racial and health equity efforts. Blue Cross Blue Shield declared racism a public health crisis, right? In the aftermath of the murder of George Floyd, and in understanding how disproportionate COVID was impacting communities of color. And I know we're going to talk about some of that coming up. So all of that led Blue Cross to make that declaration, and then I was able to join the enterprise shortly after.
So me, being born and raised in Minnesota, I have known Blue Cross my whole life and really have witnessed Blue Cross kind of being ahead of its time. I think when it comes to addressing health inequities in Minnesota, I think about the Blue Cross Foundation being formed in 1986, right, to address societal factors and impact health. I'm old enough to remember the historic tobacco settlement in the 1990s, right?
Yes.
And for our listeners who are not familiar with that, that is when Blue Cross and Blue Shield in Minnesota sued Big Tobacco and won. And the result of that was the Center for Prevention to address Minnesota's most pressing health issues. So some of our listeners might not be familiar with that history. So wondering if you'd share a little bit more about the history. I think 90 years. Did I see a 90-year anniversary? And the
Yeah.
Okay, that's what I thought. And the impacts that that has had on Minnesota and the health of our communities.
Yeah, absolutely. So one of the things that I think is really important is that Blue Cross Blue Shield, we've been working on social determinants of health. We've been working on those societal factors that impact health for a long time, right? Through our foundation and through our Center for Prevention. So that is not new work to us. That is like racial and health equity is a continuation of that work. And so through the foundation, we have three main priorities. There's healthy connections, equitable care and coverage, and then healthy start. So healthy start is around early childhood engagement, right? We understand the investments we make there have long running impacts. And so let's invest early. Let's engage there. Equitable care and coverage is about we have one of the lowest uninsured rates in the country due to our efforts to make sure that folks had access to health insurance, understanding health insurance could facilitate a more healthy life and journey. And so we partner with many others to bring that about and to make that real for folks. And then with the last one is healthy connections. And that actually has to do with sort of safe, connected communities, right? So again, this large work around how do we create sort of communities that embrace and that are inclusive. And then if we think about the Center for Prevention, physical activity, social factors, of course, tobacco cessation, and all of that work that we were able to do through the Center for Prevention. And in particular, some of the work around Freedom to Breathe, Nice Ride, the Do campaign, you may remember a dancing guy, that's part of our work. And then the Health Equity and Prevention Institute, which was a multi-year funding project that gave incredible community organizations such as Appetite for Change, the American Indian Cancer Foundation, CLUES, Zeitgeist Center for the Arts and Community, Hope Community resources to help communities facing inequities and reach their full potential through that support. So I wanted to sort of lay that down and provide that foundation level set because like that's the work that racial and health equity builds off of is that long-term work that we have been doing and the impact that we have had on Minnesota. And then the last thing I'll say is through sort of the umbrella of racial and health equity is also this narrative change work that is really critical that we do. And so we've partnered with the multi-award winning 360 Journalism TV and broadcast camps to create the next generation, right, of diverse storytellers, right? Because those creating the stories absolutely impact how the story is told. And so if we can be a part of fostering this new pipeline, right? This new generation of storytellers that are diverse, that understand community, that are from community, we believe we will see better results as well. We also have work in community that we do as well through some of our partnerships in places like Wilmer, Brooklyn Center, Winona, Mankato, and other places as well. So lots of work. In 90 years, you can do a lot of work. And so we're really proud of that work. And we also know that the work that we have in front of us requires a different muscle. And so we are leaning into that as well.
Well, and I'm familiar with much of that work. And I think the way that you have partnered with local organizations to impact change has just been leadership that is unparalleled that I've seen elsewhere. So definitely impacting change at the local level. So when I think about your long history and being a leader when it comes to racial and health equity. So we know it's the right thing to do, right? A lot of people say we do it because it's the right thing to do, but there's also a practical reason. And that is the financial cost of health inequities across our health ecosystem. And I recall a few years ago, Blue Cross publishing a report, I think it was through the University of Minnesota, talking about the cost of health inequities in our state. Can you give a few examples of how health inequities can increase the costs for all Minnesotans, the cost of healthcare?
Yeah, absolutely. So one, the health inequities, and in particular, as they impact health and outcomes in health, we have to think about the social determinants of health. So Health Affairs in 2018 put out a study about health instability and health outcomes. So understanding that it wasn't that folks just didn't want to be healthy, it was that housing instability meant what's the permanent address? Like, where do you mail information? Like, what's the how do you provide if it was health insurance cards? Where do you send those, right? That just some of those hiccups might impact health. So that's one thing, is those social determinants of health. Transportation, of course, we know is another. Transportation too, right? Appointments. So the social determinants of health, which means 80% of our health, the health that we have, the outcomes we get in health, are determined by things outside of sort of a clinic and a hospital setting, right? Which is really important context if we're talking about how do we eliminate inequities and save our system dollars, right? So we did a study. We found that while we were one of the healthiest states in the union, right, Minnesota, but we still had some large inequities, right? And those inequities cost us $2.2 billion annually for us as a state. And I think it's important that we don't run away from that, right? So I think we have a tendency to say, well, it's the right thing to do. And for most Minnesotans, we're doing great, right? And then we stop there. But what we don't often speak to or have a willingness to speak to is that the ones that we aren't serving also impacts the product and the outcomes that we are getting. That $2.2 billion, that's annually, that health inequities are costing us. That means it's impacting the entire system, right? It's not isolated to just those who sort of living in the void of those inequities.
Yeah, I just want to restate that for our listeners, because it is really almost hard to get your head around that. What I heard you say is that 20% of health happens in a clinical setting, right, in the doctor's office, and 80% of health happens outside of a clinical setting. So where we work and live and play and pray, right?
Absolutely. So great. So if we can just make it really, so to your point, making it clear for listeners, when the Robert Wood Johnson Foundation, large organization, said, let's try and figure out why we're getting some of these results, a lot of that work led to what they call the social determinants or social drivers of health.
Sure.
Right. And what they said was that how we present to a doctor, primary care physician in a clinic setting, 80% of that is due to what happens outside of that specific space. So we talk about social and economic factors. We talk about behaviors. We talk about physical environment, right? And so I think as we talk about sort of going forward, and what we realized from COVID, right, was that those social determinants, social drivers of health, social and economic factors, physical environment impacted, right, the spread of COVID, those who got infected by COVID, those who were able to isolate at home, those who were able to gain access to vaccines or clinic settings. So I think those social determinants of health, I think, is a large part of those outcomes, why we get those outcomes. And I think we do have to, one of the questions we ask around Blue Cross Blue Shield of Minnesota, and we ask some of our other sector partners, is if we really believe that body of research, what are we doing in that 80% to foster better health outcomes? That becomes a question, I think, that is imperative for all in the health sector to ask themselves. We really believe that. We really believe that body of research. How are we showing up in that 80%?
If you're just tuning in, you're listening to Finn Voices on Healthcare Now Radio. I'm Carrie Young, and we're talking to Bukata Hayes, Chief Equity Officer at Blue Cross and Blue Shield of Minnesota. That's meaningful. And I think about when you talk about, the physical environment, I also think about food insecurity, right? And people having access, not just, access to healthy food. And during COVID, that was clearly an issue. So I want to go in that direction for a little bit, since we're heading into our third year of dealing with the pandemic. And like you said, it has dovetailed with America's racial reckoning, right? We're in Minnesota. For folks who are listening, we're at the epicenter really of that racial reckoning here in Minnesota. So I recall in the early days, they called COVID, the great revealer, because it manifested inequities that have plagued our system for decades. So can you talk some more about how the pandemic disproportionately impacted people of color and help our listeners understand some of those reasons? Absolutely.
So I think you made a really important and subtle nuance, right, in terms of the great revealer. And I think we can accurately say many of us knew that those inequities had existed long before that, right? And then through COVID, we were able to then, for some, see it in a much more tangible way. So I don't want to sort of talk about sort of what COVID exacerbated, truthfully, and not necessarily unveiled, was that there have been many folks living with that for a long time. You know that, Carrie, right? Like, and so part of it is with COVID, we were able to see how sort of that lack of infrastructure, right? The presence of social determinants of health. We even know this idea of comorbidities. So diabetes, high blood pressure, other pre-existing conditions impacted, right? Who was able to, if you got COVID, who was able to, in some ways, make it through COVID. But some of those racial disparities that we saw in COVID. So one, I want to speak to that in the early days of COVID, in many of our large cities, I know Milwaukee, Wisconsin, like I think they said like 70% of the folks who had contracted and died from COVID were African American. I know that in St. Louis at one point, nearly all of the deaths from COVID in that early period were African Americans. We even know that in a sovereign nation, tribal nation in South Dakota had to close its borders to folks because COVID was ravaging their community and they wanted to put a stop to the spread. So we see clear sort of racial differences in sort of how COVID impacted our country. And in particular, the COVID tracking project, that was a project with the Atlantic, sort of laid out, right, how COVID was impacting folks. And they found that, and this would have been in March of 2021, that Black folks had died like 1.4 times more than their white counterparts, right, from COVID. And this idea that, like, was it because Black folks somehow had just attracted like this attraction to COVID? No, right? It was the presence of comorbidities. It was who was able to isolate at home, right? Because that became the thing. How do you quarantine, right? Well, we understand, right, that in some densely populated areas, you aren't able to quarantine as easily as you would like. Right. So I think those are a lot of the ways that we saw COVID impact racially. COVID was not discriminating. It infected, and folks who got COVID were of all shades, was of all colors and ethnicities. But what it did, for some maybe reveal or unveil, but we know for us it exacerbated a history of discrimination within our country, right? That then started to sort of be made real plain and clear for some folks. And so even in Minnesota, we were the epicenter, as you said, Carrie. The murder of George Floyd caused us to ask a question about how could we allow some things to get to a point where that's what we're seeing in our street in broad daylight, right? That's another one of those sort of systemic, historical questions that we have to continue to ask as we are looking at how we undo decades and centuries of sort of calcification in sort of personal, social, structural situations that have fostered inequities in health, in particular around racial lines.
That's right. And that's kind of exactly where I want to go. So you're an expert on racial and health equity, clearly. Some of our listeners might think that health is just personal, right? Pull yourself up by your bootstraps and exercise more and eat more nutritious food and manage your stress better. But help us understand why it's not that simple and how policies and systems have contributed to health inequities in Minnesota and really, frankly, across the nation.
Absolutely. Absolutely. So I just want to state really clearly to you, Carrie, that I love to talk about these things. So I want to get back to the social determinants of health. So I want to mention that, but I do want to give some really clear examples. So if I don't get back to it, you have permission to say, Bukata, come back. All right. So if we want to talk about sort of these policies, let's take a look at racialized covenants, right? That we know restricted some folks from living in parts of community that they wanted to live in. Right. So it's called redlining. We have that here in Minnesota. Right. There was a project called Mapping Prejudice that laid that out. Right. In particular, worked within Hennepin County to say, like, what sort of language was included in covenants where folks wanted to buy homes and where they wanted to live. We know that we now have evidence that the GI Bill was not sort of laid out equally for all those who wanted to access it. We have evidence of that now. But those racialized covenants basically said if you were not white, you couldn't buy property or own property in this particular neighborhood. That impacted where folks could live, right? So that's one of those sort of policies that absolutely impacted. The other I wanted to speak to was, and it comes around maternal health. So we now know that Black women and Indigenous women die 3 to 4 times more likely than their white counterparts during the childbearing process, right? That's in our nation, right? And so we have to go back a long way to take a look at a few things. So I'll speak to those quickly. One, J. Marion Sims, who's considered the father of gynecology. He experimented on enslaved women without consent and anesthesia. And some women up to 30 times. They survived those experimentations multiple times. And then we know that in some of our medical schools, there was this notion that Black women could bear more pain than their white counterparts, right? You don't have to take a long walk, right, to understand where some of that might have come from. And then we see, right, that in our current day, in our sort of, with all the technology we have and the advancements we have, that Black women still die 3 to 4 times more than their white counterparts. So those are the sort of policy, the history that is impacting the results we're getting today. And so that goes back to those social determinants of health, right? Those physical environment, those social and economic situations that we know impact the access, right, that folks are able to have. And we know that impacts who is working with folks. So the last thing I'll say about that is Dr. Rachel Hardiman did a study that found that having a Black doctor or a Black physician increased outcomes with Black patients and Black birthing people, right? So that's one thing. And then the other thing that she found through her research was that during the birthing process, Black women were offered less interventions or management for pain than their white counterparts, right? So again, part of that, we have to look at sort of what's being taught in schools. But if we go back even farther, we say, where would someone get the notion that a Black person or Black women or Black birthing people could bear more pain? And so when they are saying, hey, I'm in pain, you say, no, you ask a few more questions. But if their white counterpart is saying, I'm in pain, you say, hey, here's the interventions we have because we know you really need it. Those are some of the things that as we work on racial and health equity here in the state of Minnesota and partner across the country, those are some things that the way I would say it is we have to have truth. We have to have acknowledgement, we have to have analysis, and we have to have action. Like those things have to occur. We can't solve, if it was maternal health, if we take that example, we can't solve maternal health if we don't go back to the root of what caused and what is causing the outcomes we're getting today.
Yeah, that is really eye-opening, and I think it will be for some of our listeners as well. So as we wrap up here, obviously Blue Cross is an innovator. I would love to hear a little bit about your key priorities heading into, it's beginning of a new year, and what are your priorities as you look to continue to eliminate health disparities in Minnesota?
Yeah, so a couple of our priorities. One, we are focusing in on partnering with Black and Brown BIPOC practitioners, right? So we have some partnerships around with an organization called Hurdle, which does digital teletherapy, trained in multiple traumas, culturally responsive teletherapy. We have another partnership with an organization called Health Inner Hue, Black women-led, connecting Black and BIPOC women with Black and BIPOC women providers, right? Answering those questions, fostering those relationships. And we're investing in that next generation, right? Through scholarships and other internships and partners within the Metro for increasing BIPOC, Black and Brown providers within our networks. Those are, I would say, is our sort of large key priorities. And then we're also doing some really important work and focusing in on maternal health, behavioral health, and mental health. We understand mental health is now a crisis. And again, to the point earlier around the great revealing, mental health was critical for a whole lot of folks. And now we see that it's critical for a much larger group of folks, so we're paying more attention to it. And then also diabetes and cardiovascular health. Those are our priorities as we head into 2023.
So as we wrap here, Bukata, could you talk a little bit more about some of the lessons that you've learned over your time at Blue Cross and give our listeners an idea of where they can go for additional information.
Absolutely. So a couple of things. One of the things we learned is that community has the answers. So we want to embed ourselves within community. We want to listen, learn, and partner differently than we have before. I think the other part is that it's going to take all of us. It's going to take many stakeholders across many sectors within Minnesota. It's not just Blue Cross, or it's not just, let's say, another enterprise doing this work and they're going to sort of swing the balance, right, and eliminate racial and health inequities. It takes all of us as a community. Last thing I would say about that is we were the epicenter. As Minnesotans, I believe we are duty bound to be part of the solution. I think the rest of the country and the world is looking at us to see what are we going to do to address the inequities that we know were part and parcel of what played out on Memorial Day and the murder of George Floyd. And so for us at Blue Cross, we want to be part of the solution. We want to play our part. If you want to know more, you can go to bluecrossmn.com/health equity, and you can find out more about the work that we're doing, the partnerships that we're involved in, and how we may be able to work alongside you in the work that you're doing to eliminate racial and health inequities here in Minnesota.
That's great. And I'm just going to say that one more time. It's bluecrossmn.com/health equity. Well, you have plenty of work in front of you. And I really want to thank you for taking time out of your busy day to share some of what you've been working on and how Blue Cross is working to address health inequities across Minnesota. So thank you so much for joining us. Appreciate it.
Thanks for having me.
And to our listeners, thank you for joining Finn Voices, a show where we amplify the voices of healthcare innovators. I'm Carrie Young in Minneapolis, and we'll see you next time.
Finn Voices is brought to you by Finn Partners, a global marketing and communications agency working across industries and services. Whether inside our walls or on the front lines of health transformation, we stand together to create meaningful and measurable impact on the world around us. Learn more at finnpartners.com and follow us on Twitter @FinnPartners.